Right, it is 12:01. Thank you all for attending this webinar and thank you for sort of coming in. Let me introduce Professor Joseph No. He is a neonatologist from the University of Florida, and I think we all have read his work and part of his work with a huge amount of variations, but particularly in the development of gastroenterology, nutrition, and nowadays into different ways with multinomics and artificial intelligence for predicting outcomes, which is a very interesting sort of field, not only in neonatology, but in many sort of healthcare areas. He has authored over 320 publications and is the chairman of the board of the Hippocrates Foundation, which organizes meetings which are slightly smaller, so you can meet the speakers. And please go on their website, Hippocrates with a K, to have a look where those meetings are taking place. But today we asked Joe to talk about neonatal enteronutrition, tradition versus science. So Joseph, over to you.
Thank you, Kurt. It's a real honor to be here, and I'm going to be talking about dogmas, traditions, misguided reasoning in nutrition for extremely low birth weight infants. And here's my disclosure slide. I will have no conflicts of interest in this lecture. And let's start here with some definitions of dogma and tradition, but I'm going to show you a picture of this guy. This is Richard Feynman. He's a very smart physicist who did most of his work at Caltech here in the United States. And one of the quotes from him is, "We must be careful not to believe things simply because we want them to be true. No one can fool you as easily as you can fool yourself." And dogmas are principles or sets of principles laid down by an authority as incontrovertibly true. And we have a lot of those in neonatology. And we also have a lot of traditions, belief, principle, or way of acting that people in our particular society or group have continued to follow for a long time. And dogmas and traditions are very, very difficult to break. And I'll give you some examples of these as we go through this lecture. So here's the agenda. I'm going to talk about several things. One is the importance of early initiation of enteral feedings, enteral feeding advancement, fortification for all preterms, gastric residuals, enteral feeding while using vasoactive agents, enteral feeding while on therapeutic hypothermia, enteral feeding during blood transfusions, and glycerin suppositories and enemas. So here's a picture of a fetus, and while in utero, the fetus is getting a continuous supply of glucose, and that depends on the mother's glucose levels at the time. Protein is taken up at about 4 grams per kilogram per day, and lipids at about 3 grams per kilogram per day. This is considerably more on a per kilogram basis for protein and lipids than what we are getting as adults. And one of the reasons for that is the major growth that is occurring in utero. And in fact, during the late second trimester to the end of the third trimester, the fetus doubles and triples its body weight. And this is why so much lipid and protein is required during that time. Now, after one of these babies are born prematurely, we tend to have, at least in the past, have had a lot of excuses to withhold enteral feedings. And here's just some of them over time. You may not be using them now as excuses, but in the past, and I remember even up to the early 2000s, most of these were still real considerations in terms of enteral feeding. So examples include low APGAR scores, umbilical artery catheters are in place, babies are having apnea and bradycardia, babies on mechanical ventilation, babies on CPAP or getting vasoactive drugs. And we now, over the last couple of decades, have become a little bit overly confident because TPN is available. And we feel that we can sometimes not use the gut for long periods of time because you can actually get babies to grow on TPN. But one of the reasons we are so afraid of using the gut is because of this. This is a baby who has developed a very distended abdomen and had to go to surgery, and the entire bowel was dead. And this has been actually a myth that has been propagated over the last several decades, that all of these factors here seem to be associated with this, and studies that have been looking at this have never really shown that these are truly factors that are causal for the development of a necrotic intestine. Now, putting food in the gastrointestinal tract is very important. And this person, Dr. Elsie Widdowson from the UK, over 60 years ago, did some very interesting studies. She showed that the suckled pig's duodenum gains 42% of its weight in the first 24 hours after birth. But if that piglet is not suckled after birth, what happens is that the gut just does not grow. So when this baby is not enterally fed, what happens to the gastrointestinal tract? And I'll show you some examples. And how fast can enteral feedings be advanced? And we'll talk about that. So let's start here. What happens to the gut if you provide very little enteral feeding? And this is studies that were done in piglets. And on the x-axis here, we have enteral intake as a percent of the total intake. And here we have the DNA, protein, and the wet weight of the intestine. And you can see with very low enteral intakes, all of these factors on the y-axis are low until you get to about 40% of the total intake. Then this begins to plateau in terms of gut growth. So food in the gastrointestinal tract is what we call trophic. It is a growth factor. It helps the gut grow. What about some of the hormones in the premature infants? This is a very old study that was done by Alan Lucas and colleagues in UK in 1986. And here we have 5 different intestinal hormones: enteroglucagon, gastrin, GIP, motilin, and neurotensin. And these are the levels that you see in the black here at birth. At 6 days, if the infant is not being fed by the enteral route, you can see that these hormones do not increase. But even if they're sick or not, if you put food into the gastrointestinal tract, you get this very robust response in terms of these hormones. What about the liver? What happens when you don't put food into the gastrointestinal tract to the liver? Well, here we see 2 different livers, and this liver here shows what happens if a piglet is being fed by the enteral route. This is after 7 days. And if that piglet is getting nothing but TPN, even the gross appearance of the liver is different. And then when you look at it microscopically, you see this fat staining, ballooning of the hepatocytes. You see fat staining in the hepatocytes as well. You see glycogen staining. These are all signs of damage to the liver after only 7 days of TPN in these piglets. Now, what happens to the permeability of the gastrointestinal tract if you don't put food into the gastrointestinal tract? This is work that was done at Baylor University, Baylor Medical College, in the late 1990s. And at that time, we were still, at least in the United States, very slow in providing enteral feedings to preterm babies. So at that time, it was possible to not provide enteral feedings to some of these premature babies for 2 weeks. And that's what was done in this group here, the blue group, TPN only to day 15. The gray group received a small amount of GI feedings starting from day 4 to 14. This is 20, slightly more than 20 cc's per kilo per day of enteral feeding. And what we see here is these two bars, and these bars represent the permeability of the gastrointestinal tract with lactulose mannitol ratio. Lactulose is a sugar that will pass through the pericellular junctions between epithelial cells if they are wide open. Mannitol will go just through the cells. So the lactulose to mannitol ratio, the greater the lactulose mannitol ratio, the greater is the gut permeability or the leakiness of the gut. And the blue here represents TPN only, and that is higher than those babies who received some enteral feedings. So what this is telling us is that not putting food into the gastrointestinal tract leads to a leakier gastrointestinal tract. Another factor that happens, which is very interesting, is the microbes are different if you provide TPN to preterm babies versus if you provide enteral feedings. So TPN is seen here, A and B. This is a bar graph representing the same thing as we see here. And these colors represent different phyla of bacteria. Now, it's a little bit easier to see on the bar graphs here, but these are the TPN babies, and the green represents a phylum of bacteria called the proteobacteria. And with TPN, we see that the proteobacteria are present in greater quantities than in the control infants. In the control infants, the blue is larger than in the TPN babies. Blues represent the firmicutes, okay? The way to look at this is that the blues are the good guys and the greens are the bad guys. The greens, the bad guys, are largely gram-negative microorganisms that have a lot of LPS or lipopolysaccharide in their cell wall. And lipopolysaccharide is a substance that stimulates toll-like receptors on macrophages and intestinal epithelial cells to induce an inflammatory response. And so what we are seeing with the TPN only infants, that we are seeing more proteobacteria to firmicute ratio. The firmicutes are the good guys. They produce lipoteichoic acid, and they also ferment certain kinds of fibers into short-chain fatty acids, acetate, propionate, and butyrate. Butyrate is a fatty acid that is very important for maintenance of intestinal junctional integrity. In other words, to improve the tightness of the junctions between epithelial cells, just similar to what I showed you in the last slide. Now, here's an interesting slide from a result from a study that was done at Harvard University by Dr. Konnikova, working with Cami Martin when she was at the Boston Children's Hospital, Beth Israel. And here we see babies who were fed early, that's less than 4 days, versus babies who were fed enterally late. And these are outcomes, adverse outcomes, NEC, ROP, chronic lung disease, PVL, IVH. In the early fed group, the numbers are all lower than in the late fed group. So in other words, these morbidities are lower in the early fed group than in the late fed group. Now, this was a univariate analysis, multivariate analysis, showed the same thing, but this was a retrospective study, not a prospective study. So one can still argue that it may be that the early fed group was actually less ill group to begin with. So this is one of the potential problems with this particular study. But we do have a considerable body of information now that suggests this, that parenteral nutrition and lack of enteral feeding can cause mucosal atrophy, lack of trophic hormones, parenteral nutrition-associated sepsis. And this is not sepsis that is coming through the lines. This is sepsis that is coming through a leaky gastrointestinal tract. Remember those open, tight junctions that we see with lack of enteral feeding? Decreased mucosal IgA and also a systemic inflammatory response. These are all some of the outcomes that can happen with only giving TPN and not providing any enteral feeding. So then the next question is, how fast should we provide enteral feeding? Well, about 3 decades ago, the concept of minimal enteral nutrition was started. That is giving very small amounts for 5 days to 7 days shortly after birth. But over time, that concept has started to change, and we've been recognizing that our preterm babies can actually, for the most part, tolerate more. This was a study from the UK that was published in the New England Journal of Medicine a couple of years ago, and the title is Controlled Trial of 2 Incremental Milk Feeding Rates in Preterm Infants. And there was one group that was fed at 30 milliliters per kilogram per day, or advanced at 30 milliliters per kilogram per day. The other group was advanced at 19 milliliters per kilogram per day. And as far as adverse outcomes, the most feared of which would be necrotizing enterocolitis, there was no difference between those 2 groups. So at least when we consider the mean of these babies, these are babies less than 33 weeks gestation, one can consider that we can feed these babies a little bit faster than minimal enteral nutrition. Now, here's a study that was done in India, in New Delhi, India, by Professor Sushma Nangia. And the title of this paper was Early Total Enteral Feeding versus Conventional Enteral Feeding in Stable Very Low Birth Weight Infants. So the question here was, what about babies who are bigger preterms, babies who weigh 1,300 or so grams, 11, 12, 1,300 grams? Can we feed those babies more and not provide any kind of a standard enteral advancement? And so she had 2 groups of babies, and here we see the early total enteral feeding group and conventional enteral feeding. And this is conventional enteral feeding was going up slowly. And when you look closely at the table, the outcome variables, those babies who were in the total enteral feeding group did better with feeding tolerance. They had less culture positive sepsis. They had less necrotizing enterocolitis. Very interesting, because that's the opposite from what dogma would hold for feeding these babies. A very similar study was done at the University of Alabama in Birmingham in the United States, early and exclusive enteral nutrition in infants born very preterm. These babies were actually more like 1,500 gram babies, so they weren't very, very preterm, but very similar outcomes as with the Dr. Nangia study from New Delhi. They found that this study showed that you could actually provide very rapid onset of enteral feedings in preterm babies and didn't have to go by this very slow incremental feeding progression. So then the next question is what? What should we be feeding to these babies? In 2012, the American Academy of Pediatrics came out with this guideline, and I'll read it to you. The potent benefits of human milk are such that all preterm infants should receive human milk. Mother's own milk, fresh or frozen, should be the primary diet, and it should be fortified appropriately for the infants born weighing less than 1.5 kilograms. If mother's own milk is unavailable, despite significant lactation support, pasteurized donor milk should be used. Quality control of pasteurized donor milk is important and should be monitored. Those were the guidelines that developed in 2012, and we are now beginning to think that perhaps these guidelines can be refined a little bit. One of the problems that occurred shortly after these guidelines came out is that many of the clinicians and even parents became somewhat complacent in terms of providing their own milk or baby's own mother's milk. They just felt that donor milk was available and it's okay to just give donor milk rather than baby's own mother's milk. And this is a study that was done from our institution by Dr. Leslie Parker and colleagues. And they compared different eras after the 2012 guidelines, Group 1 era, Group 2 era, Group 3 era. This is different time periods. And what they found was that the baby's own mother's milk feeding went down after these guidelines were instituted in most neonatal intensive care units in the United States. So this is actually something that could potentially be harmful. So let's talk about this a little bit. I'm going to start with a quiz. Just want to ask you what the answer to this question is. The average protein content of unfortified donor human milk is A, the same as preterm baby's own mother's milk, adequate for optimal growth of the extremely low birth weight infant, approximately 2.2 grams per deciliter, approximately 0.9 grams per deciliter. Just think about that a little bit.
Yes,
The correct
are dropping in the chat box. So
okay.
give it a little second.
Yeah.
There's some more and more. Most would say D.
Most are correct. That's very good. It's approximately 0.9. Over the last couple of years, it's actually people have found better measurements, and it even appears to be less than 0.9 grams per deciliter. So the quantity of protein in unfortified donor milk is quite low. And one of the reasons for that is because usually mothers do not provide donor milk to the milk banks until later on in their lactation period. And they also provide their first milk to their own babies. And so what happens is that the hind milk tends to be higher in fat, but lower in protein. And so this quantity of protein is actually quite low. And so this has led to fortification. So here's a question. 30-week gestation, 1 week old, on 80 milliliters per kilogram per day, is on own mother's milk. Baby is tolerating enteral feeding as well. The baby is getting 5 centimeters of CPAP. Should you fortify these feedings? And when should you fortify these feedings? Well, I'm going to answer that with, we don't know the answer for sure. But if you have a baby who is 30 weeks gestation and really taking own mother's milk quite well, there is probably not a major need to provide fortification for these babies if they are able to take large quantities of their own mother's milk and if they're growing on this. The protein requirement for these babies, and now I'm talking about the very low birth weight baby, it's estimated to be about 3.5 to 4 grams per kilo per day for the human fetus, and the extremely low birth weight infant would require about 330 milliliters per kilo per day of term donor human milk to meet this requirement. Now remember, donor milk tends to have a lower protein quantity, lower protein concentration than the baby's own mother's milk. Baby's own mother's milk, preterm milk, the early milk in the first 2 weeks has about 2.2 grams per deciliter of protein. What about calcium and phosphorus? What do you think happened here to this baby's arm? It's broken. Baby's got a fracture. And if you look closely, the bone does not look very dense at all. And there's fairly high requirement for calcium and phosphorus in preterm babies. And human milk, this column here, doesn't really supply that which is required per kilogram per day or per 100 kilocalories. If you fortify it with calcium and phosphorus, you can get up to these quantities. Term formula has this amount of calcium and phosphorus, so term formula is not appropriate for these very preterm babies. preterm formula has quantities which is close to this. Okay, so it is thought that it's probably very important to supplement calcium and phosphorus in these babies. But here I'm again talking about primarily the very low birth weight babies, and this is babies that are less than about 32 weeks gestation, 31, 32 weeks gestation. And here we have a 23-week preterm, 1 week after birth, on 50 milliliters per kilogram per day of donor milk. When do you consider fortification of feedings? So here's some questions. 1, no need to fortify. 2, start with fortifier that provides additional protein, calcium, and phosphorus between 50 to 100 milliliters per kilogram per day enteral feeding. So when you start to get to that level, the infant should not be enterally fed. Fortification with cow's milk fortifier has been shown to cause neck, so should be started only with human milk fortifier. What would be the most appropriate answer?
Many twos here in the chat box.
Good for you. Okay, very much agree. Okay, so as far as data in terms of fortification for these babies, we have very little data on these really small babies and actually how much fortification they need. But we are still taking our best guess. But I think that it only stands to reason that the amount of calcium and phosphorus and protein that these babies require is considerably more on a per kilogram basis than the bigger babies, because they are programmed for faster growth at that time. You should provide enteral feeding. So 3 is definitely incorrect. Number 4, fortification with cow's milk fortifier has been shown to cause neck, so should be started only with human milk fortifier. I'll talk about human milk fortifier shortly, but there has never been a study that has shown that cow's milk fortifier or cow's milk formulas actually cause neck. There may be a greater risk for the development of neck compared to baby's own mother's milk, but the causation has never been proven. Here's another question. Pasteurized donor milk compared to fresh mother's milk, A, has less lipase activity, has few, if any, live cells, has minimal live microbes, is largely devoid of CMV, or all the above?
Many E's, Joe.
Ah, you guys are good. You guys are really good. So that's the correct answer, all the above. Pasteurized donor milk compared to fresh mother's milk has less lipase, has few, if any, live cells, has minimal live microbes, and is largely devoid of CMV. So here's just a nice little illustration of some of the human milk bioactive agents. In the milk, we have the macronutrients and we have the micronutrients, but we also have these bioactive agents and immunoglobulins, enzymes, growth factors, microbes, etc., are all thought to be very important bioactive agents that protect the gastrointestinal tract from injury. Now, what happens after Holder pasteurization? This is some work that was done by one of our Australian colleagues, Peter Hartman from Perth, Australia. And this is actually quite a few years old now. But if you look at certain of these components, for example, alkaline phosphatase is an enzyme that is almost completely wiped out by the pasteurization process. Bile salt stimulated lipase, almost completely wiped out. The immunoglobulins are decreased. What's not on this slide is that the microbes also are markedly decreased after the pasteurization process. There may be a few spores of bacillus remaining, but that's about it. The pasteurization process wipes out the live microbes. In the past, prior to about 15 years ago, if we cultured milk and found that there were microbes present, we thought that that was a terrible thing and we threw the milk away. But now we're beginning to recognize that these microbes actually may play a positive role in milk. Now, what about the implication of abolishing bile salt stimulated lipase? Well, this is important because pancreatic lipases are low to begin with in these preterm infants. And the bile salt stimulated lipase is higher in milk of mothers delivering preterm than in those delivering at term. And this is a lipase that helps break down triacylglycerols into fatty acids and glycerol, which are better absorbed into the intestinal tract and assimilated. So this is a very important process in the gastrointestinal tract. And if you are not providing the bile salt stimulated lipase, the breakdown of the triacylglycerols is not as good as it should be. What about alkaline phosphatase? Remember, that's another enzyme that's wiped out by the pasteurization process. Well, alkaline phosphatase dephosphorylates various pro-inflammatory microbial components, including LPS, thus making them unrecognizable by toll-like receptors. And so if you wipe this out, intestinal alkaline phosphatase, if you wipe that out, you actually can help promote the growth of some of these microbes that contain high quantities of LPS, which could potentially be pro-inflammatory. Now, what about donor milk versus preterm formula? If you did a study comparing those two, and that's actually what was done in Toronto by Dr. Debbie O'Connor, and I'm not going to get into all the details of this graph. I'm just going to go to the next slide and show you the results of this study. So this was comparing donor milk to preterm formula. And the primary outcome was neurodevelopment. So among very low birth weight infants, use of supplemented donor milk compared with formula did not improve neurodevelopment at 18 months corrected age. If donor milk is used in settings with high provision of mother's milk, this outcome should not be considered a treatment goal. But here's some interesting secondary outcomes. Donor milk-fed babies compared to formula-fed babies showed trends toward lower language and motor development. Donor milk-fed babies had higher cognitive neuro impairment and a trend toward higher language neuro impairment scores. And then fewer infants in the donor milk group had necrotizing enterocolitis. Now remember, this is very important. The primary outcome was really the major goal of this randomized controlled study. Secondary outcomes are mere associations, and there's a lot of confounding factors that may control these. So as far as the language development, motor impairment, and also the necrotizing enterocolitis, we have to be very careful with the interpretation of these outcomes. And I would not act on giving donor milk or not giving donor milk based on these outcomes. There was a study in Sweden recently published, and this is called the Jensen study. It was published in Lancet. And the goal of this study was to determine the effect of human milk-based fortification in extremely preterm infants fed exclusively with breast milk. This was a randomized controlled trial. Now, remember that there used to be mainly just one product out in the market called Prolacta. There are now several human milk fortifiers out in the market. These come from usually donors, but now over the last few years, some of these donors are actually being paid for this. But the results of the Jensen study are seen here. Routine supplementation with human milk-based fortifier is not superior to bovine milk-based fortifier as a nutritional strategy to prevent NEC sepsis, or death in extremely preterm infants already receiving formula-free enteral feeding with own mother's milk or donated breast milk. So this type of fortification, which can be very expensive, really does not show any major benefits. In our neonatal ICU at the University of Florida, we started using this about 2 years ago. And when a couple of studies came out, one from Canada and also the Jensen study, we decided to stop paying $500,000 a year for this fortifier in our neonatal ICU. So we are now back to using cow's milk fortifier. Okay, here's a question. You're on call at 2 a.m. The nurse reports that this baby, who is being fed 2 milliliters of breast milk every 3 hours, is having 4 cc's yellow gastric residual. What do you do? Well, in the past, when we saw gastric residuals, especially if they were large, and the definition of large was never really defined, or if they were yellow or greenish, they would be thrown out. And then the question arose, do we really need to be doing gastric residual evaluations in preterm babies? Think about what we do when a nurse does gastric residual evaluations. So let's say that a baby is being fed every 3 hours, and before the feeding, the nurse pulls back on the tube to see if there's a gastric residual present. Well, when they pull back, a negative pressure is created, and there's holes in the end of that feeding tube, and you can actually be causing damage to the intestinal or to the gastric mucosa by doing that. So that's one point. The other point, excuse me, the other point is that if you throw away a gastric residual, and that was commonly done, that baby has been working really hard to try to secrete acid and to secrete pepsin and other enzymes to break that down in the upper gastrointestinal tract. And so you just throw away that baby's hard work. Well, here's some pictures of some individuals. And at the top, this is Roberto Murgas, and he was a fellow in our neonatal ICU about 10 years ago. And Roberto came into my office and said, do we really need to be doing these gastric residuals? Can we possibly, routine gastric residuals, can we possibly set up a randomized study to do this? And I said, whoa, that's going to be tough to do because there's with this dogma and tradition in almost all neonatal intensive care units that we have to be doing these. So we decided that we were going to give this a try. And so we talked to this person down here. This is Dr. Leslie Parker, who happens to be one of our nurse practitioners, and she's also a professor in the College of Nursing at the University of Florida. And she was very helpful in working with the nurse manager of our neonatal intensive care unit and doing education to the nurses so that we could move forward with this prospective randomized trial. And so we did a small pilot study, and that pilot study did not show any differences in poor outcomes such as necrotizing enterocolitis, but we did see a very strong trend toward less TPN and being able to reach full enteral feedings faster in those babies who did not get the gastric residuals done. So that was our pilot study that Dr. Murgas did. And then Dr. Parker went on to submit a National Institutes of Health grant application, a large grant application, to look at this prospectively. And with well over about 160 patients that were randomized in this study, we found very similar results. No increase in necrotizing enterocolitis, increased feeding tolerance, and we were actually able to get these babies out of the hospital faster. So here's the summary again. Omission of routine gastric residual aspiration was not associated with intestinal dysbiosis or inflammation. Existing literature indicates preprandial gastric aspiration does not reliably correlate with development of necrotizing enterocolitis, but does correlate with delayed enteral nutrition, the data that suggests routinely monitoring preprandial gastric residuals show that this is an unnecessary procedure. Our study is not the only one. There have been several other studies done since, and there's a very large trial that is being undertaken right now in the United Kingdom. But we've found that we are satisfied with the data as it exists, and we have stopped doing routine gastric residual evaluations in our neonatal ICU based on this data. Here's another case. 27-week preterm is being treated with indomethacin for patent ductus arteriosus. It is most appropriate to stop enteral feedings, B, continue enteral feedings, provide only hydrolyzed formula, obtain an abdominal radiograph as a baseline in case you want to rule out necrotizing enterocolitis. If you want to give me some answers, be glad to.
A couple of B's rolling in.
Okay.
All B's rolling in.
Oh, you guys are really good. Okay, I agree. Continue enteral feedings. And the data on that has really, I think, been convincing over the past several years. So here's a physiologic basis that helps us understand this better. This is a study that was done in piglets at Baylor a couple of decades ago. And they looked at superior mesenteric artery blood flow in these piglets during enteral feeding and during TPN. So here, during enteral feeding, we see this nice high superior mesenteric artery blood flow. You stop the enteral feeding and give only TPN, the superior mesenteric artery blood flow goes down. This is a well-known fact. There is a hyperemic response to feeding in the intestine. Why were we so afraid to feed babies during indomethacin when we were giving them indomethacin? Well, the concern was that the indomethacin would decrease blood flow to the gastrointestinal tract. But this physiologic data actually shows that if you give indomethacin and stop enteral feedings, you'd be worsening the situation. So from a physiologic standpoint, feeding would probably be the best thing to do. This is a study that was done by Ron Kleiman at University of California, San Francisco, and the title was Enteral Feeding During Indomethacin and Ibuprofen Treatment of a Patent Ductus Arteriosus. And I'm not going to go into the details of the results, but I'm just going to read the main results to you, seen on the right here. Infants randomized to the feeding arm required fewer days to reach the study's feeding volume endpoint, 120 milliliters per kilogram per day. And there were no differences between the two groups in the incidence of infection, necrotizing enterocolitis, spontaneous intestinal perforation, or other intestinal morbidities. Another question, do you keep feeding during blood transfusions? Well, a couple of decades ago, big concerns were raised about necrotizing enterocolitis and blood transfusions. And here's one study that suggested a very large, high relationship between transfusion-associated necrotizing enterocolitis. And this raised a lot of questions. And if there's a strong association between these transfusions and necrotizing enterocolitis, it was considered that maybe we should stop feedings during transfusions. Well, the whole question of transfusions causing necrotizing enterocolitis was actually started to be was questioned. And here's two studies, one from our group at University of Florida, the other by Bill Bennett's group at Stanford University. And what both of these studies showed was that packed red cell transfusion is really not associated with an increased risk of necrotizing enterocolitis in preterm infants. And that was very contrary to the previous considerations in the previous studies. Then Dr. Ravi Patel at Emory University did a study with a large number of patients, 598 patients, and also found that red blood cell transfusion in a given week was not significantly related to the rate of NEC, but rather the rate of NEC was significantly increased in babies with severe anemia in a given week compared with those who did not have severe anemia. So the anemia appeared to be a greater culprit here than the actual treatment for the anemia. So this suggested that, again, the rationale for not feeding these babies was a very poor rationale. And here's a study that looked at feeding during transfusion and the risk of necrotizing enterocolitis. And here is the conclusion. No significant decrease was noted in the rates of transfusion-related gastrointestinal injury after feeds were withheld during transfusion. But this was a small study, and they recommended further studies. But at least in this small study, it did not show any harm to feed the babies during transfusion. Okay, let's get to another circumstance. What about babies who are getting hypothermia for hypoxic ischemic encephalopathy? Should you feed these babies, or can you feed these babies using the intestinal tract? Well, the first question is, why not? We have considerable data showing that there are major advantages, such as decreased mortality, inflammatory responses to feeding in patients who are under high stress conditions, such as burns and trauma. So I think that we need to ask the question here, why not? How did this start? Well, it was just considered that babies who are under hypothermia may have low blood flow to the gastrointestinal tract, and with that, they may be at greater risk for development of intestinal injury. But it was noticed that in Scandinavia, where feedings were being done in babies under therapeutic hypothermia, and in UK, there was no difference in terms of necrotizing enterocolitis. So that was just something that raised a flag here that said that maybe this should be looked at a little bit more closely. And, oops. This is a study that we did at the University of Florida, and the title was Enteral Feeding as an Adjunct to Hypothermia in Neonates with Hypoxic Ischemic Encephalopathy. This was not a prospective randomized trial, and this was done in a small number of patients. But the results were of interest and certainly, at the very least, hypothesis generating. So we found that at 24 hours, the median IL-12 P70, this is a pro-inflammatory mediator, concentrations were lower in the HIE neonates that received minimal enteral nutrition during hypothermia. So inflammation was lower in those babies who received some food in the gastrointestinal tract. And we also found that those babies who were fed got to full feedings faster, had less TPN, et cetera. So we are now feeding these babies at the very least small amounts during the hypothermia process. We hold off the feedings temporarily during the rewarming phase, but again, that's something that we really don't know the data for, but we're still trying to be a little bit on the careful side by not feeding these babies during the rewarming phase. Here's a meta-analysis looking at therapeutic hypothermia and feeding. And the conclusion here is that in late preterm and term infants with HIE, enteral feeding appears safe and feasible during the cooling phase of therapeutic hypothermia. The last area I want to talk about is, does evacuating the rectum and colon with suppositories or enemas improve feeding tolerance and decrease NEC? Well, I have found that there are quite a few neonatal ICUs where this is being done almost routinely because of this concept that you're going to improve feeding tolerance and decrease NEC. This is a study this is a meta-analysis that looked at several different studies. And the conclusion in terms of glycerin suppositories is that glycerin suppositories provide no additional benefits to preterm infants. So the answer to this question was no, that we should not be doing routine suppositories or glycerin or enemas in these babies. If you want to look at a review article in feeding issues in babies less than 25 weeks gestation, this is a paper that we published in Seminars in Perinatology just a couple of years ago. And we discussed the various issues that I just talked about, some of the various issues that I just talked about in this lecture, in this paper. Now, why personalized precision nutrition? Well, this is where we are going in the future. Right now, we have guidelines in our neonatal intensive care units, and I am very much in favor of guidelines. But the problem with guidelines is that one size does not fit all. And the guidelines are really aimed toward the mean. And here we have a 23-week gestation preterm and a 29-week gestation preterm. And these babies are obviously different in their nutritional needs. And in the future, we should be able to use artificial intelligence, multiomics, and some of our new technologies available to provide precision nutrition to these individuals. So just stay tuned for the next several years, because I think we're going to be seeing some changes in terms of this particular area, personalized nutrition for preterm babies. So here I want to summarize. Neonatology is still a young discipline, and clinical judgment without strong evidence base remains highly prevalent. It's good to have clinical judgment, very important to have clinical judgment, but it's also important to do studies and to have a good, strong evidence base. Dogmas based on clinical judgment frequently stick, but may not be in the best interest of our patients. So we need to constantly question our practices and develop as much evidence as we can upon which to base our practices. So evidence-based science provides many answers, but it's not easy. Randomized controlled trials can be very costly, sometimes millions and millions of dollars for some of these randomized controlled trials. But the future will provide new technologies, including augmented intelligence and multiomics for prevention, diagnostics, and treatment. And even the way we do science, instead of doing prospective randomized trials, this new concept of digital twins holds some promise in being able to do precision-based studies on our infants. And I think that this is going to be the wave of the future. So thank you very much for your attention. I'm very happy to answer any questions.
Thank you, Joe. This was a great overview, big topic, but I really appreciate how you approached it. It's about physiology and the pathophysiology, where the physiology says, why not? And interestingly, our dogmas and tradition is the other way around, is just not feeding. So you went to different feedings, different data there, different mixes where the evidence is one limited. And I guess the comparisons are always not that clear to the reader. Some had mother's own milk and PDHM, some with fortifier, some not. And the duration of that is very variable in the limited data which is offered to us. I did think you approached all these different scenarios where people tend to not feed in enough way. So let's start with some questions. There's a couple of them in the chat box already. Sanjay Wazir from Kids Health had some questions. Maybe Sanjay, you want to unmute yourself and ask the questions?
Yeah, thank you. Thank you for a lovely presentation. And my two questions, one is about the Jensen study. Now, it was done in a very developed part of the world with the infection rates being very low. I mean, do you think this is going to be a general statement that like that human milk based fortifiers are bad, especially given the fact that in countries where sepsis rates are very high, and also like in the follow-up studies maybe required to determine if we are missing out on any long-term benefits of exclusive human milk benefits, which may not be captured in the initial analysis. And the second question.
Yeah,
Sorry.
let me try to finish that that question. That's a very, very good question. And certainly studies done in one unit or a small number of units in one region of the world may not be applicable to other places. So I totally agree. I think that this is something that we do need to consider as a possibility, that this may be an important factor. But it does show that reasonably, I think, well done study that that the actual human milk fortifier did not provide any real benefit compared to the cow's milk fortifier, and the cow's milk fortifier did not cause was not associated with any kind of increased risk to the patients. Again, only one study, but I think it's very compelling.
Okay,
And
Samuel, sorry, was there another question, Sanjay?
Yes, there's one more question. You did present some of the data on lack of intestinal alkaline phosphatase in donor milk, and it was quite scary. Is there a way for commercially to add intestinal alkaline phosphatase to donor human milk, given the fact that it still remains our next preference after mother's own milk?
So, this is only one factor that is present in baby's own mother's milk and fresh milk. And so I think that there are, industry would be very interested in doing this kind of a thing. And it may be possible, but one of the problems is that an enzyme, if you put it into the stomach, the enzyme will be hydrolyzed, at least partially hydrolyzed by the stomach. And by some of the other, the acid in the stomach will change its properties. The proteases in the upper gastrointestinal tract will beat up the enzyme as it goes down further into the gastrointestinal tract. So, is it possible? I think it's possible to do this with some kind of a delivery system, but I don't think it would be easy to do.
Okay, thank you. Sam from Singapore has a question for you.
Yes.
Hi, Joe. It's a great talk as always. I have a couple of questions. One is, some of the, we give lectures in the regional developing countries, often come across growth restricted babies, bad asphyxia, lower Apgar scores 1 and 5 minutes, metabolic acidosis, lactic acidosis, and hypotension needing inotropes. Such a situation, is it safe to feed? You mentioned, studies done in some part of the world may not be applicable to some of the developing regions. In my experience, if they feed, the baby may develop florid neck in such a situation.
Well, let me start with Sam. It's so great to see you. I haven't seen you for years. You look great.
Thank you.
Yeah. So I think that you raise a very interesting point. And again, there is experience that people have with babies who may have been very, very sick to begin with. And, there's a reason to use inotropes, and that's usually something like septic shock. Those babies are already very, very sick. And it may not be putting in the food that is causing that baby to get sicker. That baby may have been on the trajectory anyway. So that's just, one way to look at it. I don't know the answer to that, Sam. I really don't know the right answer. The studies that have been done have been very, very minimal. I still like to feed babies who are on inotropic. So if they're on dopamine, dobutamine, even norepinephrine, I like to put small amounts of food into the gastrointestinal tract for the reasons that I showed you before. You know, physiologically, you actually increase the blood flow to the gastrointestinal tract. So again, I can't tell you that I know the answer to that. I can tell you what I do and what my rationale is.
Thank you, Joe. The other thing is, you know, you mentioned several advantages of the artificial intelligence and also, you know, the precision medicine and even the feeding, which is going to come in a few years. And, you know, but at the same time, you are mentioning that randomized controlled trials may not give the answer. But you see, sometimes depends on the question and the background knowledge and application. You know, one of the fairly large study from the database of UK, you know, tend to show formula is better than human milk and donor milk. You know, it revolutionizes the concept. You know, Alan Pippa's study in the early days, if you start with formula compared to breast milk, the neck rate is 7 times.
Yeah. We have different babies now than we had in, you know, the early Lucas studies that showed the 7 times. We have babies now, and this is again a whole different lecture. We're talking about necrotizing enterocolitis, and you know, the definition and all the different problems that we are calling necrotizing enterocolitis. There's probably, you know, at least 5 different clusters of intestinal injury that we are putting under this name, necrotizing enterocolitis. So I think we need to go back and make believe that we're in the 1970s and start all over again in some ways, and use some of these technologies to better define intestinal injuries in these babies and not call everything necrotizing enterocolitis. You know, probably I would say the vast majority of babies that we give the label necrotizing enterocolitis to have no necrosis of the intestine.
Thank you.
So it's a misnomer.
Yeah, thank you. Look, I think we have time for one more question. There's a couple of questions in the chat box which are about details, which I will email to you, Joe.
Okay.
The last one is interesting though. Justine, you wanna open up and answer this question?
Yes. My question was, you mentioned that you no longer use human milk derived fortifier from that study where there was no reduction in neck. So I was just wondering, this means you use a bovine fortifier, I'm guessing. And
Yes.
from when in the feeding schedule? So do you fortify from sort of the first feeds or, you know, as a result?
Yeah, the actual timing of fortification is still sort of a question. And again, some of these bigger babies probably don't need fortification if they're, you know, relatively healthy and taking their advancing well on their enteral feedings. I would posit that those babies don't even need the fortification. But then your really small ones, you know, your 24, 25, 26 weekers, those babies, I'm pretty convinced, even though we have very few good clinical trials to support this, but I'm convinced that they really do need some fortification. And so I like to start somewhere between 60 to 100 milliliters per kilo when they are receiving that volume of feedings to start fortification. I don't have any strong reason why you couldn't start fortification at the very beginning or or earlier than that.
Yeah, that's an important question in many centers actually. And I think what I do hear, and also from you in this talk, that many centers are rethinking their approach to feeding. So I guess that is just good progress wherever you go. and let go of some of the old dogmas and traditions. Joe, I want to end it here. Thank you so much for staying up late and presenting for us. And thank you all for attending. Next week, we have another meeting where Dr. Blank from Melbourne is going to talk about how, if you video resuscitation can improve our performance in resuscitation. Thanks again, Joseph.
Thank you.
Thank
Have
you.
a good day.